Now we are studying posterior pituitary hormones. So the two hormones from the posterior pituitary, oxytocin and antidiuretic hormones. Antidiuretic hormones, also called vasopressin, that are released from the posterior pituitary are actually synthesized and in hypothalamic cells. ADH's vasopressin is chiefly a product of supraoptic nucleus. From supraoptic nucleus, vasopressin is made, while oxytocin is derived from primarily paraventricular nucleus. So when you learn vasu, va for vasopressin and su for supraoptic nucleus. And for paraventricle, you should remember oxytocin, O pia, okay, vasu O pia. So O for oxytocin, pia for paraventricular nucleus. Ironically, therefore, the term posterior pituitary hormone seems to be a misnomer because these hormones are actually synthesized in the hypothalamus and then simply emptied into the posterior pituitary. So upper side is hypothalamus and from there it is going to the posterior pituitary and then simply emptied into the posterior pituitary capillaries from where these are drained into the systemic circulation. Out of these two hormones, vasopressin and its antagonist has been dealt extensively in other we will study later. Now we are studying oxytocin. Oxytocin is derived from the term oxys, that is quick, and tokos, quick tokos, that is quick toko to it, that is childbirth. Childbirth oxytocin. Hence from the term oxytocin, it appears that the essential role of oxytocin should be in the parturition, childbirth, but it is not. Its essential role is milk ejection. Incidentally, again, the name oxytocin dose does not match to its principal physiological action. In the same way, like a vasopressin still being used in place of antidiuretic hormone. Okay, so main function of oxytocin is milk injection, but here now oxytocin is a peptide hormone secreted from the posterior pituitary whose primary role is in milk ejection in a lactating mother. It also has a facilitatory role in the initiation of labor and parturition. The interrelationship between pharmacological actions of oxytocin and the factors controlling oxytocin release are here. Like this oxytocin release. Okay, so contraction of myoepithelial cells from the mammary gland causing the milk ejection that result in milk ejection happening. Infant is suckling the milk, suckling by infant, stimulating the mechanoreceptors in nipple. Then it is going to hypothalamus. This stimulation, then hypothalamus stimulated causing the secretion of this oxytocin by stimulating posterior pituitary and then oxytocin release. What is happening? Uterine contraction increase in case of labor. Positive agabolic action. Reflexes originating during the formation of birth canal. And that is stimulation going to hypothalamus, again posterior pituitary, increase oxytocin release. Causing oxytocin also causes vasodilation that result in decrease in BP. Oxytocin causes weak ADH like effects, weak antidiuretic hormone like effects when it is in high dose. Pharmacology. Now oxytocin has a circulating half-life of 5 minutes. It is not bound to the plasma protein and it is metabolized by the liver and excreted through the kidneys. 2 mg is equal to 1 international unit of oxytocin. Pharmacological action. Breast. Oxytocin causes contraction of myoepithelial cells surrounding the mammary alveoli leading to milk ejection. Suckling by the infant stimulates nipple mechanoreceptor which in turn convey impulses to hypothalamus. This promotes the release of oxytocin through the posterior pituitary, which further provokes milk ejection. Uterus pharmacological action of oxytocin. Estrogen sensitizes the uterus to oxytocin action, while progesterone decreases this. Estrogen, like in the menstrual cycle also, first estrogen is being released, later on progesterone. So a spike or graph is there. So estrogen sensitizing the oxytocin action, but progesterone decreasing it. Non-pregnant uterus, and that during the early pregnancy, they are resistant to the oxytocin. Only 8% sensitivity. So in this case, it not affects. But in pregnant uterus, it's more sensitive. The sensitivity increases rapidly, and during the last trimester, it's maximum at maximum at the onset of the labor. The sensitivity of oxytocin during threatened or actual abortion, the myometrium of the uterus is very sensitive to oxytocin. At the onset of labor or during the abortion, oxytocin increases the magnitude as well as rate of contraction of upper segment of the body of the uterus. If there is a uterus, it is causing the upper segment of only high magnitude of contraction, that is fundus, and this is further facilitate relaxation of cervix because due to the pressure from the fetus head and the lower segment of the uterus, that is body. The cervix are already in the process of relaxation, so it is causing the high contraction also with relaxation also. Contraction at the upper fundus side and relaxation at the cervix side, so causing the birth of the baby. Thus, oxytocin facilitates and coordinates the already existing uterine contraction and in benefit of childbirth by preparing the birth canal. Sensory nerves of the vagina are stimulated by the pressure generated by the fetus head, propagate reflex and send impulse to the hypothalamus, which further promotes and release oxytocin from the posterior pituitary. Local prostaglandin release also increase oxytocin. Locally, if prostaglandin is released, it will increase the oxytocin, which further stimulates uterine contraction during labor. The cycle goes on till the childbirth takes place and oxytocin level then quickly falls during puerperium. In high doses, oxytocin causes vasodilatation. In high doses, vasodilatation, a decrease in the blood pressure and reflex tachycardia. Oxytocin helps in closure of umbilical vessels at the time of the birth. Oxytocin in high doses exerts weak ADH-like action in high doses and has mild antidiuretic effects. Oxytocin receptors are found not only on the uterus but also in the limbic system. Animal model reveals that oxytocin plays an important role in the mating and parenting behavior. Oxytocin is also released during the sexual orgasm. Now we are studying oxytocin receptor antagonists. Oxytocin receptors are G-protein coupled receptors, GPCR, which when stimulated leads to the generation of IP3 and subsequent mobilization of calcium from the intracellular stores, and depolarization is induced activation of voltage sensitive calcium channels. Oxytocin receptor antagonists, they are GPCR, G-protein coupled receptors, which is when stimulated lead to generation of IP3 and IP3 generation and subsequent mobilization of calcium from the intracellular stores, and depolarization induced activation of voltage sensitive calcium channels. The number of oxytocin receptors differs at various stages of pregnancy and increases significantly late in gestation, which parallels the marked increase in the myometrial sensitivity to oxytocin. An oxytocin receptor antagonist, atosibin, has been recently approved to inhibit the premature labor, that is, or preterm labor. It is administered IV bolus followed by continuous IV infusion for not more than 48 hours. Adverse effects include nausea, vomiting, vasodilatation, hyperglycemia, and rash. Therapeutic uses to promote milk ejection and resultant breast engorgement. Intranasal spray of oxytocin 25 to 30 international unit is made into each nostril in sitting position 2 to 3 minutes before nursing. It is also used in milk yielding cows to facilitate milk let down. However, milk does not increase the milk production but increase the milk let down. Then injection process. Initiation and augmentation of labor. Oxytocin used to induce labor in the following conditions, like in situations requiring early vaginal delivery, such as conditions including RH problems, maternal diabetes, preeclampsia, erythroblastosis, placental insufficiency. For this purpose, oxytocin is given by slow IV infusion containing 5 IU, 5 international units of oxytocin and 500 ml of glucose normal saline. The infusion may be accelerated according to the response. The drug is discontinued if uterine contraction becomes very strong. Uterine inertia, oxytocin 2 to 5 IU in 500 ml of normal saline can be infused slowly to augment contraction if uterine contractions are feeble, very less. In case of that, we can use oxytocin. Oxytocin should not be used to accelerate normally progressive labor, only for feeble labor. Control of postpartum bleeding, oxytocin 5 international units, IM or IV infusion provides immediate response. IM injection of oxytocin after placenta is expelled, causes tetanic contraction of your uterus and arrests postpartum hemorrhage. Des-amino-oxytocin, it is a buccal formulation of oxytocin which is convenient to administer but is less potent. Its dose schedules and uses are as under induction of labor. Des-amino-oxytocin for 50 IU buccal tablets are repeated 30 minutes till the desired effects are obtained. Maximum dose is 10 tablets or 500 IU. For uterine inertia, 25 international units every 30 minutes till the desired effects are obtained. In case of breast engorgement and milk letdown, 25 to 50 IU just before breastfeeding. Adverse effects and contraction. Non-judicious use of oxytocin can lead to fetal and maternal soft tissue injury, rupture of uterus and fetal asphyxia. If the oxytocin is being used not judiciously, these problems can happen. It has a weak antidiuretic effect. Hence, the larger dose are used along with the normal saline NS because water intoxication may result, which may be serious in cases of preeclampsia. Contraindication of oxytocin includes cephalopelvic disproportion, breech presentation, placenta previa, and fetal distress due to aneurysm. In such situation, delivery by cesarean section is preferred. Thank you.